All right. Well, hey, everybody. Dr. Bulow here, and happy to have you. Thanks for joining me again. Once a month, as you may know, I like to do these clinical conversations with some really cool people, like Dr. Andrew Dulak DPT. So thanks for hanging out again, Andrew.
Thanks for asking me.
I think we've done this before. So if you look back, or people look back on the Dr. Ian Bulow Facebook page, they'll probably find that. I probably hashtagged it clinical conversations. But otherwise, either way, if you look up clinical conversations with the hashtag there, you'll see conversations that we've been having with different clinicians. And Andrew's somebody that, like I said, we chatted before, and has been it was a fun time having you out. We had early morning coffee one time, now we're having it in the afternoon. But Andrew's a physical therapist who specializes in a lot of different things. But I know you have a kind of a special love for the golf pros out there. But maybe that's how we'll start off. You can kind of remind everybody who you are and where you practice and kind of what your practice comprises of primarily, and then we'll get into some of the clinical conversations. So.
Yeah, so my practice is Dulak physical therapy and golf, so I do have this love for golf, but it has evolved. Before I was strictly golfers, but what I found out with golfers, a lot of them have aches and pains, not specifically related to golf. So it has evolved to just everyday life. And it has transformed into a mobile physical therapy practice. So I'll get to go to your houses or your jobs to make it easier for you to receive quality care for you instead of trying to fight the traffic or go to a clinic.
I actually know a couple chiropractors that have gotten into that model a little bit, you know. So it's kind of, and so I'm guessing with that, not to cut you off, I want to go back to what makes up your primary practice, but so I'm guessing that necessitates that you're mainly active rehab, right? You know, which
Very much so.
Which I think is probably more long-term effective. You know what I mean, when it comes to full recovery and things. So yeah, what makes up the majority of your patient base? Would you say? I mean, are they golfers? I'm guessing a little bit, but in general, who's the? I don't want to use the word target market because that's more of a business term. But clinically, where are your home runs that you tend to see more often than not?
Yeah, I really see myself like working with people that are very active and they want to take ownership of their own health. I mean, if you're going to invest your time in, basically time in to enjoy your life a lot better with your family, friends, all different things, and you want to know why you're doing it and you want to do it for 20 or 30 years down the road. So a lot of people in their 30s and 40s and 50s that are starting to find new aches and pains. You wake up and you never know what you're going to have. You could have a knee issue or a back issue and you just don't know why, and you want to
I haven't
nip
hit
it
40
early.
Yet, but I've heard that's when it starts.
Yeah,
Random new things.
I'm in my 30s, and I started waking up, and I'm like, oh, what is that issue? And then I go through my assessment and figure it out. But it's when you want to find out why you're doing it and nip in the butt before it gets bad.
Yeah. There was one of my mentors, and again, sidetracking from the in-depth clinical stuff that we will get to, but there was a term that was used to me by a mentor of mine. He said he would ask his patients if, do you want your health span to match your lifespan? You know what I mean? Because like if you're going to, here's your lifespan, however many years it's going to end up being, we don't know, but however much that is, how much of that do you want to be healthy? And it's kind of like, well, that's an interesting question.
I mean, do you want to be 80 years old and just sitting in a chair just watching TV? Or do you want to be 80 years old playing golf? Or going down to Florida and going for those walks, get on the beach and not have the fear of falling because you know that you're healthy enough. So I want to be a healthy 80, 90, 100-year-old. Who knows?
I like it.
Yeah.
So let's start with, because sometimes I have patients that'll listen to these conversations. So let's start with some practical things that might be good for us as clinicians to talk to our patients about, so that we avoid needing the more in-depth professional care. Because as much as we want to take care of people, the reality is what all of us want is to see less doctors over time and live our life free of any interference and things like that. So what are some of the lifestyle mistakes that you catch in the patients that you see where you say, oh man, you got to knock that off, or we want you to do more of this? We'll get into what you do clinically for them professionally, But let's just start there. Just any insider tips that you notice that are like, oh man, this is for sure what we could straighten out pretty easily.
Yeah. Well, everything in the news right now, we're talking about like sitting is awful for your body.
Smoking, right?
Yeah, exactly. So when you're talking about sitting, if you're sitting more than 7 or 8 hours, that's a big factor, because a lot of different things, specifically clinically, like when you're sitting, your glutes are your butt muscles, but they're just not working. Basically, the back of the chair is holding you up, and you're not really doing too much.
Yeah.
So if you're sitting for 7 or 8 hours at work, and then you go home and you eat, you're sitting. Most people sit when you, and then
you're driving.
And most people are tired, so they're going to watch TV or read a book. So you're sitting again. So some people can actually sit for about 22, 23 hours or be in that position. Even when you're sleeping, you're in that bent position where your glutes aren't working. So that's a big thing. If you're sitting for 6, 7, 8 hours, you should be up and moving at least 30 minutes, 45 minutes, walking, doing stairs, doing something outside. Just being on your feet would be huge.
Yeah. Do you notice ergonomically, because you're portable, I'm curious if you've done assessments on people at their workstation or at their desk or different things to assess the way people are sitting? Any thoughts on that? Like any, again, cardinal sins that they're doing that they need to stop doing? Like for me, I notice I always tell people to pretend like they've got, these giant industry utility magnets in their belt, and that every chair you sit on for the rest of your life is made of metal, which means you've got to take that belt line and push it against the back of the chair that you're sitting in, and then sit up. So there's not that rabbit hole of space between, because if you have that space, you're rounding, like you're mentioning, compressing the back. Is there anything else that you're noticing when you're on site with people's workstations or in their home environment, particularly in their sitting environments, that are red flags for you? Or anything on the flip side of that coin that we can do in our sitting life to enhance it? Of course, we got to get up and move around. But is there anything that we can do to enhance the quality of our sitting posture? Like, again, like sitting back would be one of them, but anything else that you've noticed in general?
The easiest ones are make sure your feet are flat. You can imagine how many people have chairs that are too high and their feet are propped up, and then they're putting them up on the, a wall or underneath the desk. And make sure your feet are flat, because if your feet aren't flat, then your back will tilt, and then you start leaning forward away from the back. So, and where the people they're working on the desk, keyboards, just simple keyboards. Just if you can follow a rule of like 90-90, that's the easiest rule. So your knees stay at 90 degrees, your elbows at 90 degrees. That will put you in an ideal position, and that forces you back, just like you were saying.
The hips at 90 as well.
Exactly. So super easy. But following even with desk work. Driving, I did a car assessment, because driving, again, we might be in the car for 45 minutes to an hour, and a car is different than an SUV, so just how the seat is positioned. So people want that straight up back, and what I actually see is, like in cars, it's going to push you kind of forward, and now you're not at 90-90 in the hips.
Oh, that's really interesting, because the seats sit back a little bit,
and that pushes you forward into a bad position. So adjusting that, actually one of my big things that I want to do with back pain people is to look at how they sit in a car.
I had a patient send me a photograph. She had some coworkers send take pictures of her at the work desk. So we had talked about her ergonomics and whatnot, and it's amazing because we don't see ourselves, and very often we are in these compromised positions and we can't even assess for that ourselves. So to your point, I think it's important for everyone to focus on. I think the 90-90 rule is great. I think it's all great. Now let's get a little deeper when we get into the clinical work, because that's kind of the impetus of this, is that there may be the very analytical patients that maybe get value out of this, but my goal for this is for clinicians. So how can, the dentist or the chiropractor or the vision therapist or, we have a functional medicine doctor or whomever, if a patient comes in and say, I'm having this kind of, like in my world, we're looking at the spine from the top down. So we see a lot of people with spinal dysfunction, radiculopathies, and all the rest. But differentiating between a spine-based problem versus a biomechanic lifestyle problem, thoracic outlet syndrome or something more distal that may and there's a lot of layover between the two of us, but maybe need some stabilization, especially in our world when we actually do our job right, and we have indicators for this in upper cervical, and in any good clinical care you have indicators, but that the spine, we've done our job. That the axial skeleton, or at least the spine itself, is really quite stable, but they're having reoccurring XYZ symptoms. I would like, for my top of mind, but everybody in my community, to be able to ask a patient a handful of questions, or to do a pretty simple in-office examination that we could say, oh yeah, that's a really bad movement pattern, or oh yeah, that's a indication of a destabilized joint right there, to know when they need to see someone like yourself. And again, because I'm a chiropractor, most people would think that I've got all that in my repertoire, because nowadays you can almost not tell the difference between chiropractors and PTs. But within my specialty, there's pretty hard lines of distinction, and we're really good at what we do, but we don't actually play in all the other realms ourselves. I'd rather refer out for that kind of thing. So I like the extra education because it's not really in my wheelhouse. And so I'm curious about that. So maybe we'll focus on the major joints outside of the spine, namely the shoulders and hips, because there's, oh my gosh, so much mobility there and so many potential issues. And so maybe we'll start with shoulders and go down. What are some of the bigger problems that you see people for in your clinic? Like what are the top 3 diagnoses of the shoulder? And then what are some simple tests that entry-level clinicians could do again? Because again, in my world, it's kind of like if someone's going to the dentist or the ophthalmologist, and they're just talking to them, and they may just in passing say, I have this reoccurring blank. Maybe it's frozen shoulder, maybe it's radiculopathy. It wouldn't take too long for someone who's got a physician's degree, they know their orthopedic tests, everyone has to have that stuff, to, I'm sure, run some field tests on them. So what are your top 3 conditions, and what are some things that we can do to kind of detect those, that sort of thing?
So let's start with a very common one is rotator cuff tendonitis. That's one.
I'm sorry.
You have a story about that
I don't mean to interrupt. I talk too much, but you might just get an appreciation out of this. My sister's a PT, and early on in my career, she said something like, everybody comes in claiming they have a rotator cuff, and she's like, it's one specific tendon. It's not the whole thing. It's the supraspinatus, and yada, yada, yada. Is it, when you say rotator cuff, you mean just a rotator cuff kind of global dysfunction, or specifically a supraspinatus issue?
Yeah, so most commonly is the supraspinatus, and they'll come in and say, I have rotator cuff dysfunction or tendonitis. So specifically, supraspinatus is what I see very commonly, and it's just because of how it passes through the glenohumeral joint, and that's number one. That's the first one.
With that one, do you find that it's just an overuse injury, or do you find that in most cases people have done something that has torn that? Because due to how it comes out of the glenohumeral, is it because they're just doing a lot of repetitive motion in that joint, or do you find that a lot of your cases injured it somehow? What's more prevalent?
I see more in the repetitive phase. For my clientele, I see it for more repetitive.
Golf and tennis and things like that.
Exactly. Tennis is a big one, but it's also, pitchers are a big one too.
Of course,
in the past years, high school pitchers, but it stems a lot from posture. And you'll hear me say this bunch through the shoulder impingements, rotator cuff issues, posture, because if the glenohumeral joint, where the supraspinatus comes through, if the scapula is up and moved forward just slightly, then that compresses that area a little bit more, and it actually, the repetitiveness of it. And then it typically, one specific movement will just set it off, like reaching in the back of a car, grabbing that purse or something in the back seat, and you yank it up and around, and then you put maximum force on it. But I think it's slowly getting worse, and that's just a...
So you're probably doing a lot of shoulder retraction, stabilization sort of thing and whatnot. And I'm trying to remember, in school, I know there's the test where you're raising your arm out, and there's certain degrees where you can kind of peg the supraspinatus versus the deltoid. So just as a reminder for most people, if you have a patient stand nice and tall and arms at the side, what does that test consist of to where you'd say, oh yeah, that's definitely supraspinatus? So I mean, there's that, you could probably palpate it too.
You can palpate it. It's a little harder because you have to expose it. So pushing a little bit back, and because you're pushing through trying to expose it, but then the deltoids are covering over
Got
top
it.
of it. But putting yourself in scaption plane, so 30 degrees out towards the side and thumbs up versus thumbs pointed straight forward and then down will just that position and testing and see where the irritation is and how strong you are. And if you're straight forward versus straight out to the side, if you come out to more like 30 degrees there, you'll see that.
Gotcha.
So
you're saying, with, just to clarify, and again, because my intention here is people who may not do anything orthopedic. So you're having a patient stand, right? We're standing nice and tall, and we're just bringing our arms straight out in front for starters, and you're pushing down against resistance.
Yep.
And then coming out 30 degrees lateral.
And then thumbs up and thumbs down. So
thumbs
full,
up
full
is
can, empty can.
Exactly.
Yeah, that's a test I think you're talking about. So empty can, exposing
and the empty can is what's going to accentuate the pressure on the supraspinatus, right?
Yeah, it helps pull in that muscle a little bit more and eliminate some of the other muscles that will compensate.
Yeah, I remember that one, the empty can test. It has there's another formal name for it, but it's emptying the beer can.
Yeah.
And then is when you are doing resistance, raising your arm straight overhead, the first or last so often is supraspinatus versus the delt, correct? Isn't there a difference between this upper range of motion versus lower? I'm trying to remember. Is that not as good as the...
Not as good. Because there's just
enough.
so much playing into it once you get above 90 degrees with the scapula rotating up when you hit certain degrees of movement, and then how the humerus kind of glides down. So that's you're taking into full effect about like activities that bother it, and then we call them special tests. And special tests just help lead you in one way or the other, but it's a full test to see what's causing it. And then we're talking about supraspinatus tests, but there's two other ones that are external rotators that are also sometimes affected with the supraspinatus.
Gotcha.
So those have to be ruled out as well and analyzed. So being specific is hard, but it takes some time to do and go through a full examination.
Lots of people have had these issues that aren't clear now, that they should see someone like yourself to have it done right, have it assessed appropriately, because like you're saying, there's layers, and especially for crying out loud in the shoulders and hips, so many different comorbidities, So before, just real quick, before we move on from the rotator cuff, the chief complaint is typically a pretty localized pinpoint pain, correct? There's not as much radiculopathy with that one, not as much as kind of like right here.
There's pinpoint, but there's also some, we're talking about referred pain. So people will say, oh, my bicep is hurting.
Really? So they will get a referred pain from this?
You do. So
interesting.
They'll say, oh, it's hurting down a little bit mid-arm. That's a big one. And you push on it, and they're like, no, it doesn't really hurt. But then you poke in the shoulder, and then you're like, oh, I feel it down here. And that's more lateral when we're talking about supraspinatus.
Got it.
If it's more in the bicep, another common shoulder issue is bicep tendonitis, which people don't know that it runs into above, so it attaches a long head, and you can feel it snap over if you put your hand here and just like roll. That's another one, but that's more like it refers down to the bicep area.
Got it.
So
Got it.
I
like that.
Yeah.
And that's probably I'm guessing one of the most common things, the supraspinatus overuse, all the rest there.
Definitely.
What's another one in the shoulder there?
The bicep tendon.
Just
I would say that's number two of that, I would say, because of how they kind of play with each other. And
test for that's a little bit trickier, right? Is that the one where you're coming out into the side to see if it kind of like snaps out of that groove? Or is that a different one that I'm thinking
There is
of?
a different one.
Okay.
I like the one where you're similar muscle testing.
Okay.
So first palpation. Palpation's super easy for bicep tendon, long head.
Gotcha.
So basically you go and find that groove that you can snap over that muscle. And that little tendon, people are pretty hot there, where they'll, that's exactly where it is. Then the test is like, well, where you want to look at. So resistance, palm up. Expose it a little bit. Get everything out of the way, like deltoids, that kind of stuff, and just trying to hold that. And when you push on the palm or the forearm or the elbow, it's easier for people to hold against when you push at the elbow because it's not as far.
Oh, interesting.
But pushing down here, and then they'll say pinpoint spot right there.
So the long head, will have more of a fulcrum with the elbow in extension as opposed to just having them at 90 degrees, flexing the bicep like making a muscle.
Yeah, because it's a two-joint muscle. The long head crosses. It's up here, so that's where this is. But if it's down, then you're not talking about that shoulder. So just exposing it a little bit more.
Love it. That's one of those little ones that'll be nice for me because I didn't ever think about that one. That's good. I like it. Any other favorite shoulder things you see relatively often?
The last one would be just like generalized irritation inside the joint. Impingement, just a term that just says, oh, I have shoulder pain, and you can't really tell which one it is. If you see something like that, posture is a big one. And I go back to like the middle back and try to analyze
Let's actually talk about that real quick, because when we talk about posture, I was fascinated when my daughters went and had their braces done, because they take photographs of their facial features. So they stand in front of the camera, they take a picture, and then they take x-rays. And I was thinking, oh my gosh, you guys are doing like 2 of the main top 5 assessments that we do. So as clinicians, you can detect if they have spinal problems better than a lot of people. So there are some of these other professions that are looking at posture, but they don't look at it the way that you look at it. They don't, you know what I mean, or the way that I might look at it. So when you're looking at someone's posture, how do you assess it from when it comes to when someone's shoulder is at risk? Are you looking at the rounding kind of nature of it? Are you looking at it from the front with the tilt on one side or the other? How are you assessing for posture?
Yeah, I'm looking at more shoulders from the standpoint of where they are positioned, and specifically I'll look on the front at somebody to see what's going on, plus with the tilt, right? To see if one's riding lower or higher. But then I'll definitely go on the backside and look at the scapulas or the shoulder blades and stick fingers down just to analyze
just that. Just see how level they are.
And is it protruding forward or are they down and back? Where are they? And most times with rounded shoulders, they're going to be coming up and in. So basically that's just going to compress that joint like we're talking about. So I look from more of a backside position.
From the posterior.
I like that angle just to get the exposure of that.
So again, for the standard practitioner that may or may not be familiar with this, you're having him stand in front of you, the arms at their side, essentially.
And you're just comfortable position. Whatever they want. I say, stand normal. And people say, I don't know what standing normal is. And then just talk with them for a little bit, maybe like a minute or two, and then they go into their natural posture.
That's funny. And then for those other, just to complete the picture, they're going to lay their hands over the shoulder blades and let their thumbs slide down to that groove at the bottom where the resistance just falls off. Correct? Just because I think that's something that, again, anybody can do. A dentist could do it, an ophthalmologist could do it. We in the manual therapy world are probably more familiar with some of these landmarks and using our hands and actually putting our hands on people. But it is something that anyone could do. They could say, let me just check this out. Oh, yeah, you've got this contraction or rotation, and whether, and that's where there are options in there. But I think that it's just good to know if someone needs an acute management of that situation, say, Andrew sees people like
this. If you want a simple one, a super simple one, is when they're standing, like posture, and just watch where their hands go. And typically round it's like they'll turn all the way in, and their thumbs will turn all the way in.
Oh, I see.
And their shoulders basically are telling them to go in. So if you're like, I don't know what I'm looking at with my scapulas and angles and all that, just see where their hands go. Some people will actually put their hands on their thighs, which
even when they're standing up, they're resting
inside that way, because look at your shoulders already go in
like that.
Versus nice and relaxed.
It reminds me of the We Are Two Wild and Crazy guys in Seinfeld, or not Seinfeld, but Saturday Night Live. The big guys, they always kind of, the elbows come out, the thumbs come in. And what I was going to say is, when I assess posture, I'll actually look at the hands and the thumbs particularly and see if one is higher or lower, because a lot of times, and now we put stickers on the AC joints as reference points when I take our photos and do our posture analysis. But what I try and tell parents, because I want them to assess their kids to see how their posture is, I say, just stand nice and tall, march in place and relax, and then look down at their thumbs, because their hands may be clenched, one might be clenched, one may be relaxed, but the thumbs are usually resting. And if their shoulders are off, one higher, one lower, the thumb tips will drop. You know what I mean? If you put a level across their thumbs, all of a sudden, then you look back up and say, oh yeah, those shoulders are a little off, But even for myself, I used to never look at posture. My mentors were more segmental, when I got to the Diplomate program, we started looking more globally at like the biomechanics of the axial spine, and that's when I started looking at all this stuff. Ironically, I don't do so much from the back. I may need to start, which is kind of ironic as a chiropractor. But I love that. I love looking at the hands.
Yeah.
So now I'm going to have to look at that rotation aspect.
Yeah.
Love it. So good gems. I hope you guys are getting some gems too, because I'm getting some little fun ones that I'm going to add into my analysis. Like, uh-oh, you got to start looking at this. So let's chat a little bit about the hips then.
I love the hips.
Do you?
I do. I think a lot stems from the hips.
I do. Because it does, right?
Yeah.
I mean, that's your power, that's your base. Now I'll tell you something, a quick story, because I have to give a little plug for my field, which looks at it top down. Because I remember I was in school, and there was an upper neck chiropractor there. And in chiropractic, there are different techniques, right? Mm-hmm. And there's a lot of them that are similar to the foundation approach, which is get the base right, work your way up because of weight bearing and all the rest. And in particular, well, I won't even name names, but they were talking about one technique, which is bottom up. And the upper cervical guy said, well, he had it right. He said, but the problem is in the human body, the engines, like, because you look at a building, all the power to the building comes from the bottom. You know, all the engines and all the gas and all the whatever. He goes, but in the human body, it's an upside down building. He said all the direction and the analogy I could give, or not the analogy, but the actual clinical application would be torticollis, scoliosis, movement pattern disorders that are obviously neurological. You'll see twists in the spine, and it's actually a brain problem. Mm-hmm. So if you take that clinical appreciation of how the brain can contort the spine, and then you apply that on the most subtle level, that's what we're looking at. We're looking at if irritation in the communication pathway between the cerebellum and the hip stabilizers are off, there may be those issues. But at the end of the day, whether it's that or whether it's a postural issue or a reoccurring issue, the bottom or the end result is, heck yeah, the hips and the base are important. Yeah. But it was just a funny little story talking to an old timer. He gave the analogy of the building. I was like, oh, that's kind of all right.
Yeah, I think that's why I think what you do and what I do, like, just collectively, it's like, well, the signal's not going down, but once the signal's there, then you can improve it. Yep. That's why I think when we're working together with patients,
100%,
it's it's
beautiful
easy
thing.
Yeah, it's like, well, fix the whole system, right?
I agree.
I love that.
Agree.
Yeah.
So give me your top one or two, maybe three, but your top at least one or two conditions that you generally see down in the pelvis, and what are a couple checks to kind of like some people could just clinically look at, even if we don't have any unique tools or devices that we could detect.
Simple ones. So we're talking about the hips. So hip bursitis is one of the big ones, especially like when you're hitting 45, 50, 55, 60 years old. Hip bursitis, just pain on the outside of your hip, right?
Lateral side. Yep, because patients will say, oh, my hip hurts, and then they'll point in a variety of places.
All over.
So when you talk about bursitis, you're talking lateral, off to the side where your seatbelt clicks in. That's the bursitis we're talking about. All right.
And you can put your hand on that side of the hip that the bone's pushing out. You know, that bony, and it's just below that is the bursa. So that's one of the big ones. And people will love to stretch with bursitis. They're like, oh, I'm going to stretch it, I'm going to stretch it, I'm going to stretch it. And after a couple months, they're like, it's not getting any better. With all the muscles coming over top of that area, it's I look at strength. Because as you're sitting since you're like probably 20, 25 starting work, the muscles get weaker in the glutes. And there's too much pressure there. So one of the easiest tests is the squat test, which I love to film to really analyze. So if you don't have any, if you don't have your phone or if an iPad or anything like that, and you just want to watch them, you can detect how a person squats, and if their knees go in, we call that valgus, where they go into like knock those knees.
Yeah. Knock knee and bow legs
out.
Sorry. Yep.
Knocking them in. Yep. So if they go inward, there's less stability around the hip. So to hold them out, so that your hip muscles hold your knees out.
Yeah.
But if you don't have that sufficient strength, the knees will go in and puts a lot of pressure right on that area where the bursa. And people always will say, oh, that hurts.
Because your glutes are extension and external rotation, right?
Abduction. Yep.
abduction, yeah.
So abduction. Yep. So those hold them out. So if they're too weak, they allow them to go in, causing repetitiveness. We talked about that with the shoulder, and going up and down steps, squatting down, getting out of a chair, you'll get that repetitive irritation.
How do you differentiate in a patient who's got knock knees between a weak glute situation in hips versus a flat arch in the foot? Because I wonder about that. When the arches drop, people's knees pop in. You just assess the arches? Is that just kind of just do that? Or do you do a squat test or something else to see, is it coming from the hip or is it coming from down here? You
Perfect. Yeah, like you said, it could be come from the top or bottom. Yep. So you have to assess it. So post it. So put something there.
Under the foot, you're saying?
Arch, yeah. So
got it.
Put like a towel or something that will create that arch.
Got it.
Or a doorstop is sometimes you can use.
That's
and
great.
Put it, like if you have that and you
I
put
like
it there.
that a lot. Just stick that
People
underneath.
have it, right? Yeah.
I love it.
Wedge it in there.
Yeah, that's great.
Towels, and you wedge it in there so they can't drop down, and then you say, do it again.
Perfect.
And
Love it.
They can do it.
Yep. And that usually indicates weak glutes in the system, essentially. Very good. I like that.
Yeah.
And you're just having them squat down, looking for that bow-legged, or not bow-legged, I keep saying that.
Yeah.
Knock knee.
Knock knee,
internal,
yeah.
coming in. Another fun little joke story from my upbringing in chiropractic college. In any kind of healthcare school, when you're learning direction of motion, as some of you may recall, adduction, bring it towards the body, abduction, away from the body. We had classmates that would say adduction, as in adduction.
Oh, yeah.
You know what I mean?
Adduction,
Yeah.
abduction, yeah.
I said adduction, but it's really adduction because it's the word add with action there, adduction. And then AB to differentiate, so they sound a lot. But people would say adduction versus abduction. We're like, but that's causing the same confusion. You say AD, and I might think you're saying B.
Yeah.
Just call it adduction and call the other one AB. The first one, just say it the way. It was just kind of like frustrating. Some people would actually say adduction.
That's how my class was. Like,
Really?
It's like it's abduction, adduction, and you say it really quick. It's like, oh, what did you say? And slow down, but it's a very common one.
The whole point of saying AB is to differentiate it from adduction.
Yeah. So I gotcha.
But anyhow, that's a little pet peeve of mine. What's another one?
All right. So squat test is one of my favorites. Number one, I love to see that. The second one is, can you balance and stand on one leg? That's a super simple test. Anybody can test yours.
Gotcha.
So if you can't stand there on one leg, if you're wobbling all over the place, to hold yourself up on one foot, unless you have a really bad ankle issue or knee issue. I mean, you're talking about the hips and the core.
Gotcha.
So they work so closely related.
Yeah.
So everybody can do that. If you're in the office and you're like, where's that stability? Is it a balance issue?
Yeah.
Check the balance. Just
Interesting.
stand on one leg.
Stand on one leg.
Shoot for 30 seconds. Eyes open.
Yeah.
You can't go wrong with that, just to see if they can do it. And I'll tell you
That's
what.
a good general test for really any hip dysfunction or instability, I would assume.
Yeah.
You know what I mean? Versus the squat test is probably really good for those external rotators, glutes, things like that. Or, just want to make sure I clarified, because that's just a good test in general, it sounds like.
And the last one is a bridge test. So you're laying down on your back with your knees bent, with feet on the ground, and you lift your hips off the floor.
Off the floor,
So
yeah.
you make a bridge, or your body goes in the spine, goes flat. So that is a big test for me, because a lot of people will say, I feel it in my back, or I'll cramp up. I don't know if you've ever done a bridge where you cramp up.
I've never had the cramps, but you should feel it in your back, though, because you're working the back muscle to a certain extent, right?
To a certain extent, but mostly it's a glutes are pulling you up and lifting you up. So if you feel it like cramping in your back or cramping in your leg, your hamstrings are overactive and they're pulling you up in there. So
I love it. I love it.
You can do a two-legged bridge. I really like to do two-leg. A lot of people love that, and it's easy. And then you want to challenge them, tell them to kick one leg.
Oh, yeah.
Oh, yeah, you'll see. They'll cramp up, pain, all kinds of stuff. So those are simple tests you can do, lying down on a floor, and you just say, do a bridge.
But see, that's a beautiful distinction, because when people do planks and bridges, I always figured it was helping to stabilize the core, because the back aspect of it, when it's going, oh no, this is the glutes pulling it up, And again, kind of like squats and why they're good for you, it's the rehabilitation of the glute more than anything. And again, on the rehab side, it's less of the focus. That's for you to figure out and take care of. But it just, in my mind, goes, oh yeah, that makes sense.
Yeah.
So bursitis, yeah, that was on my, I've got, some fun stories, but I don't want to bore you. Any other of your favorite hip issues or things that you see?
A lot stems from the hip. So I will say, like, not so much hip pain unless they'll say, like, in the groin. So people say, again, where's your pain? Oh, it's in my hip. And they'll point
to the groin there?
In the groin area. So that's actually the true joint of the hip. That's where it is. And that's another one, hip impingement for golfers, specifically my population, because a lot of rotational. That's a lot of rotational.
We have a common patient that talks about a lot of that, about the swing and about all the rest.
A lot of rotation.
If someone's, what are some of the symptomatology of having like a hip impingement like that? Like, where do they notice it in their day-to-day? So there's the golfer, right? But what about the standard Joe or gal that doesn't necessarily play golf? Like I was talking with someone the other day where we're so linear in our movements that we may not even know we have an issue until we just catch ourselves, and all of a sudden we had no range of motion there, and we end up with an injury. Are there any other movement patterns other than golf that people notice these types of problems during? Do you hear that from your patients? Like, this happens every time I get out of the car, or every time, what would a patient say to a clinician that says, my hip bothers me when I is there anything like that?
Yeah, so if we're talking about hip impingement, it's some form of twisting. So pivoting is a big one. So if you're in the kitchen and you take a pot from down below and you try to put it on the counter and you just turn with it and you don't move your foot, which a lot of people won't, they'll just like twist their hips and that foot stays planted, they'll say, oh, that's every time. Anytime I pivot into that hip.
Got it. Yep.
Groceries, from the cart into the car.
Yeah.
In the back seat, they grab it, turn, every time I feel it right in my groin area.
Got it.
So
it's the location and the mechanism of rotation, not to be confused with a couple of those analogies involve bending, where people can get in trouble with the lower kind of sacrum to the lumbars and whatnot. So this is more, it can happen with them totally standing, just rotating and kind of making those kind of coupled motion of the hips kind of jiggle around there. So we're turning into it.
Yeah,
I see what you're saying.
So bending also, when you are in a flex position or bending at the hips, it compresses too. So what the test is actually, or putting shoes and socks on when they try to lift up and do this. Yeah. That's another one where they might have pain. But a simple test would be, hip impingement. You bring your knee up in a flex position and you turn your foot out. Yeah. So you're compressing that area.
So for the physical, or excuse me, for the massage therapist that may be listening in, if anyone does or watching in, this can be tested too with them lying prone, right? You flex the knee up in the position you just mentioned, and then with the knee at 90, you can take the foot out, and it would kind of be the same thing, correct?
Yeah,
a little bit there.
Lying on your back. So we, in our world, we call it supine. Right, supine.
Yep.
Head looking up, and what you do is you flex it up to around 90, 100 degrees.
I see what you're saying.
And knee bend, and then you pivot the foot out.
In chiropractic college, we had the one where you were prone 90 degrees, and that might be more of an SI or something along those lines, because the distinction there that I didn't catch initially is you're actually flexing at the hip and then twisting out. I didn't catch that. So okay, I got it. Oh, that's cool. I know you're on limited time, and I've gained a lot of little gems, and I love it. And it's just fun, man. I think we've got, like I said, these indicators, because there's a lot of overlap in a lot of our professions. But when our own indicators are running that we've done our job, these are some great ones to be like, you know what? I think it's not, in our world, we'd say it's not a chiropractic issue. It may be this hip issue, which a lot of people would call a chiropractic issue. But for the upper cervical traditionalists, we stick to vertebra. I got to tell you another fun little story. I had a traditionalist, a guy that just staunch upper cervical, or not upper cervical even, he was just staunch chiropractic only, spine only, which again, I respect a lot of that. I'll never forget it. I was driving him. I picked him up at the airport. We're driving to our halfway party. Halfway through our chiropractic career, we had this little celebration, And his name's Reggie Gold. He's passed away, God bless him. May he rest in peace. Great guy, did amazing things for the profession. But he held the line with what chiropractors should stick with chiropractic. This is what it is. This is what it's not. And you stick with it. And in school, we were going through classes where we were looking at neuromuscular systems and extremities and different things, because the schools are way more liberal than they used to be. And I remember talking to him. I said, "What do you think about extremity work? What about this? What about that?" And he was so funny. He goes, "My whole life, I've tried to find a vertebra in the knee. I haven't found one yet." Because in his mind, he goes, "If it wasn't a vertebra, it's not chiropractic." You know what I mean? Like, it was just black and white.
Yeah.
And it was so great, because I remember thinking, I'm like driving him, I'm like, conversation over. All right. But I do think that there's a respectability in knowing the lines, because then you can play with confidence and comfort with others, because it's like, no big deal. It doesn't make me any less of a chiropractor, because you do what you do, I do what I do.
Yeah.
And but it was just, I love Reggie. He had a way with words, and was a good guy, really good guy for the profession. But like I said, this has been really good. I really appreciate your time, Andrew.
This was awesome.
For any practitioners that are in the greater Pittsburgh area, or just want to connect with you, you know what I mean, and talk maybe specifics on golf management and things like that, maybe someone who does what you do but is in a different state that wants to maybe brainstorm with you, where can people find you, that kind of thing, on websites, Facebook? I'll link it up on the video too, but for those that may be listening in, where can they find you?
Yeah, well, I always love connecting with different providers, so locally or across the country, just because I think we have such a wealth of knowledge that we want to learn. That's why I love coming and chat with you, because I'm learning stuff from you, and then we're sharing everything that I'm doing. So my website is Dulak Physical Therapy in Golf. We'll tag it to this.com. Dulak, D-U-L-A-K. You feel free to email me at dulakpt@gmail.com. And if anybody wants to reach out to me with my phone, local area, 412-437-1798.
Awesome. I really appreciate it, Andrew. Thank you so much for hanging out with us. Thanks, guys, again, for hanging out and spending the time with us. We will talk to you next time.
All right. Thanks.
Bye now.